The clinical problem identified for the project is the continued reliance on opioid-based analgesia for postoperative pain management in adult surgical patients. Although opioids are effective for treating acute surgical pain, they're also associated with adverse effects such as nausea, vomiting, sedation, respiratory depression, delayed gastrointestinal recovery, increased opioid exposure after surgery, and increased length of stay. The issue matters specifically to nurse anesthesia practice because CRNAs are directly involved in increasing or creating intraoperative anesthetic plans that balance the effectiveness of pain control with patient safety and recovery. If the problem is not addressed, patients may continue to experience preventable opioid-related side effects, increased rescue opioid needs, and inconsistent postoperative recovery outcomes. To guide the project, the final PICO question is as follows. In adult surgical patients, does the use of intraoperative intravenous ketamine, intravenous lidocaine, or intravenous magnesium sulfate infusion compared with opioid-based analgesia alone reduce postoperative opioid consumption and postoperative pain scores? This question guides the evidence selection by focusing the literature search on adult surgical patients who have received intraoperative non-opioid IV adjuncts and by prioritizing the studies that measure postoperative opioid use and pain scores as primary or clinically meaningful outcomes. The PICO question also keeps the project focused on opioid-sparing techniques rather than broad pain management interventions. High-level characterization of the evidence, the overall strength. Overall, the body of evidence is moderate and somewhat inconsistent in terms of the strength. The strength comes from the fact that several studies are randomized controlled studies and evaluate clinically relevant outcomes such as pain scores, opioid consumption, recovery quality, and adverse effects. However, the evidence is not completely consistent because the studies vary in surgical populations, dosing strategies, medication combinations, and comparison groups. Some studies evaluate using a single medication while others evaluate using multimodal opioid-free or opioid-sparing regimens that include several medications used together. Because of this, the evidence supports multimodal opioid-sparing analgesia as clinically relevant strategy, but it doesn't support that there is a one-size-fits-all strategy for every adult surgical patient. Areas of agreement and disagreement. So, high-level characterizations of the body of evidence demonstrates the areas of agreement that the postoperative pain management should not rely on opioids alone, and the studies collectively support the use of multimodal analgesia because of non-opioid adjuncts can target pain through different mechanisms than opioids and may help reduce opioid exposure while maintaining acceptable pain control. The evidence also agrees that pain scores and opioid consumption are appropriate outcomes for evaluating perioperative analgesic strategies. Although there are agreements within the literature, there's also areas of disagreement in which the studies do not consistently show that opioid adjuncts are superior to opioid-based analgesia. Some findings support that lower opioid consumption or improved pain scores, while others show pain control compared with traditional opioid-based approaches. And there's also uncertainty whether the benefits come from one specific medication, such as lidocaine, ketamine, or magnesium, or if it's from a combined effect of the multimodal regimen. Because of this, the evidence supports a selective patient-specific opioid-sparing approach rather than eliminating the opioids completely.
Evidence gaps and limitations. Key limitations of the evidence. Studied surgical procedures, patient populations, and hospital analgesic protocols varied across the studies. Ketamine, lidocaine, and magnesium sulfate were administered in various doses, timings, and infusion durations. Pain assessment methods and follow-up periods were also inconsistent across the studies. Applicability issues specific to anesthesia settings. There is current evidence of the benefits of multimodal analgesia and opioid-sparing analgesia, but there is no established Standardized protocol for all adult surgical populations. One unanswered question that could affect implementation. What is the optimal non-opioid agent and dosing strategy for controlling postoperative pain in routine CRNA practice? The proposed practice change, the selected intervention. The intervention that was chosen was the implementation of a clear, standardized multimodal pain management plan that utilizes low-dose intraoperative ketamine for adult surgical patients expected to experience moderate to severe postoperative pain. The proposed practice change, justification from evidence. Low-dose intraoperative ketamine consistently reduced postoperative opioid consumption and pain scores. Ketamine demonstrated opioid-sparing benefits across multiple adult surgical populations and has a beneficial safety profile at sub-anesthetic doses. Although evidence supports the use of magnesium sulfate and lidocaine as pain management adjuncts, ketamine demonstrated the strongest and most consistent evidence for treating postoperative pain. Evidence supports implementation of low-dose intraoperative ketamine for postoperative pain management despite variations in surgical procedure and patient populations. Anticipated impact, CRNA practice and patient outcomes. For patient outcomes, low-dose intraoperative ketamine improves postoperative pain scores while reducing opioid consumption rates. It also decreased opioid-related adverse effects including nausea, vomiting, constipation, respiratory depression, and sedation. It was also proven to promote enhanced recovery with early mobilization and increased patient satisfaction. CRNA workflow or practice. This multimodal approach provides CRNAs with a standardized, evidence-based multimodal analgesic plan that has been shown to consistently improve postoperative pain management and opioid consumption. Anticipated impact, cost considerations, and unit operations. Unit or system operations. Standardized ketamine protocol will promote consistent multimodal analgesia and reduce variations in CRNA practice and patient outcomes. Reducing postoperative opioid requirements may decrease opioid-related adverse events and improve the efficiency of the PACU. Cost considerations. Ketamine is an inexpensive and widely available medication that does not require additional purchase of equipment. A decrease in opioid-related complications will decrease length of PACU stays, hospital resource utilization, and overall costs.
Successfully implementing a standardized low-dose intraoperative ketamine protocol requires active support from several key stakeholders. CRNAs, anesthesiologists, surgeons, and perioperative and/or PACU nursing staff are directly responsible for delivering and monitoring the protocol. Pharmacy and perioperative and/or anesthesia leadership are also essential, since they oversee protocol approval, develop the order set, and allocate the resources needed to support it. That said, several barriers could still slow its implementation. Providers may be unfamiliar or hesitant with standardized dosing, especially without an existing order set built into the electronic health record or EHR. There's also variability in surgeon and provider preference for opioid-based techniques, along with some concern over ketamine's potential adverse effects. To address these barriers, a few key resources are required. A standardized evidence-based ketamine order set directly integrated into the EHR, along with provider and nursing education materials, competency evaluation, and CRNA super users to support adoption and guide implementation of the protocol in its initial phases. Successful implementation of the protocol also depends on thoughtful education and a clear rollout strategy. CRNAs and other anesthesia providers will need an in-service reviewing the standardized dosing protocol, the supporting evidence, and ketamine safety profile. Additionally, perioperative and PACU nursing staff will require education specifically on monitoring for ketamine-related effects. Before using the protocol independently, providers should also complete a competency evaluation to demonstrate their understanding. In terms of strategy, we recommend a phased rollout, beginning with CRNA super users on high-volume surgical services, and from there, case-based audit and feedback, along with ongoing provider support, will help guide a smooth adoption throughout the transition process. In order to evaluate the success of this practice change, we propose 3 key metrics. First, we have the primary outcome metric, which is the 24-hour post-operative opioid consumption, measured in morphine milligram equivalents. The process metric being assessed is the percentage of eligible surgical cases that actually receive the standardized ketamine protocol. In other words, our order set compliance rate. Finally, our balancing metric looks for any unintended consequences, such as the increased incidence of ketamine-related adverse effects or an unplanned increase in PACU length of stay. So let's say the implementation proves effective. This change could be sustained by integrating the protocol into existing EHR order sets and incorporating it into onboarding for new CRNAs, supported by continuous audit with feedback and periodic review of outcomes by perioperative quality leadership. On the other hand, certain indicators would prompt us to revise or discontinue the protocol altogether. For example, increased rates of adverse events, low provider compliance, or a lack of improvement in pain management and opioid consumption. Finally, this work has legitimate potential to evolve into a full DMP capstone project. It could be formalized as an IRB-approved quality improvement initiative with pre- and post-implementation data collection and formal outcomes analysis across the practice site.